Dr. Venkat Nagaraj is requested to come to the dais, and he will be speaking on newer drugs for anticoagulation in atrial fibrillation.
I would like to thank the SCVS team for inviting me to give this talk. Now, I was asked to talk about newer anticoagulants in stroke prevention and atrial fibrillation. Now, there are lots of new drugs that are exciting and that are now coming up. So 15 minutes is a short time to wrap up all these drugs. So what I will try and do is I'll mention these drugs and we'll talk about one or two drugs in detail that are there. So just a brief background about stroke and atrial fibrillation. We know that atrial fibrillation is an important cause of stroke. We know that of all the strokes that are caused, 15 to 20% are because of underlying atrial fibrillation. And warfarin has been used as an anticoagulant in atrial fibrillation. Now, of course, we got other options. We got aspirin, we got combination of aspirin, clopidogrel, and then warfarin. So there are various risk stratification mechanisms such as CHATS, SCORE, where we can stratify which patient is going to benefit from aspirin, which one from warfarin. We know that aspirin reduces the risk of stroke by about 20 to 25%, aspirin plus clopidogrel about 50%, and then just warfarin on its own about 66%. So warfarin clearly in patients who are high risk, whose CHATS S2 scores or CHATS VAS scores are more than 1, they will definitely benefit from taking warfarin. Now warfarin has been in use for last 50 years. This is a bog standard drug, we all have heard about it. But in day-to-day life, there are some problems with use of warfarin, all the more in Indian patients. I worked for about 15-16 years abroad, so I have come back to India in the last 15 months. So I see the difference and the difficulties of use with warfarin. One, warfarin, we want to do sort of regular blood tests, target an INR between 2 and 3. So for this, the patient needs to go for regular blood test. And based on the blood test, we'll have to change the dose of warfarin. Warfarin has multiple interactions, both in terms of drugs and food. So for an average Indian patient and also Indian physician who's following up these patients, it becomes slightly difficult to do this. And also if the dose is not changed or if the patient is not having regular blood tests, we know that INR can go hayward, patient can have intracerebral bleeds, and especially physicians are not comfortable prescribing warfarin for elderly patients where there is lots of falls and other issues. So warfarin, with all its disadvantages, the advantages is very cheap, one, and two, it's got an antidote. If somebody comes with warfarin overdose or is in bleeding, we can give vitamin K and we can be happy that yes, there is an antidote, at least. So people have been on lookout for an alternative anticoagulant for a long time. So what is the ideal anticoagulant? We have not yet found, but one that can be given without any need for regular blood test, one which has got wide therapeutic margin, one which has least interactions, and which is also affordable. So this dream drug we have not yet found, but we have found something very similar. So if you are looking for an alternative anticoagulant, first of all, we got to understand the coagulation pathway, so where we can target. So there is lots of drugs that we can target, that we can use, and these drugs have been used in phase 2 and phase 3 trials, but I would like to bring your attention to few drugs which are already been in use. One is dabigatran, which is factor 2A or a thrombin inhibitor, direct thrombin inhibitor, and then we got apixaban, rivaroxaban, and edoxaban, which are factor 10A inhibitors. These drugs are also in trials. So, as I told you, these are the drugs. The drugs that are out in market that have been used are dabigatran, rivaroxaban, and apixaban. Of this, dabigatran has already got Indian FDA approval, is widely used in India now. So let's talk about dabigatran first in detail, and then I'll briefly touch about rivaroxaban, apixaban, and then we'll compare these and we'll take things from there. So dabigatran, sorry for the background. There is one big study called RELY trial, 18,000 patients, and the patients are mainly non-valvular atrial fibrillation. This is very important. This is not for patients with rheumatic valvular heart disease. Warfarin is still the best drug. So for non-valvular AF, these patients have been grouped into 3 groups. One is warfarin group, one is dabigatran 110 milligrams twice daily, and other is dabigatran 150 milligrams twice daily. So it's a fairly robust trial with 18,000 patients. So you see, the main purpose of this trial is to see that dabigatran is non-inferior to warfarin. We are looking for an alternative to warfarin. So what we are looking for is a non-inferiority. If it is superior to warfarin, well and good, we will take it. But if it's as good as warfarin, we want to replace warfarin. So here we see that all strokes and systemic embolic events. So this is warfarin, this is dabigatran 110, and this is dabigatran 150. So this is non-inferior to warfarin. Although it is less, it is not statistically significant. It is not inferior to warfarin, as good as warfarin. This is statistically significant reduction from 1.6% to 1.1%. So dabigatran is good that way. So major bleeding, again 3.36 with warfarin, 3.1 with dabigatran 150, and 2.6 with 110 milligrams of dabigatran. So this is not statistically significant, but between dabigatran 110 and warfarin, that is statistically significant. So again, the same slide. So there was some concern raised during this trial whether more number of myocardial infarctions happened in the dabigatran arm. A lot of people feel that this is by chance because this is not a statistical difference, significant difference, and between 110 and 150 as well, it's 0.82 and 0.81%. So just let us know slightly more about dabigatran. What are the side effects? What are the adverse effects? We don't need any blood test with this drug. There is no antidote. The common side effects are dyspepsia. That's the major in about 11.3% of patients. So let's move on to the next drug, Rivaroxaban, and then we'll compare all of them. Again, this is a Rocket AF trial. It's a fairly comprehensive trial with good numbers. We got 14,000 patients on this trial. But these patients are slightly higher risk than the one that were used in Relay trial. They had to have at least 2 or 3 of these CHAT score criteria. So these are patients who are at high risk of having stroke. And they were again randomized to warfarin or Rivaroxaban 20 milligrams daily or 15 milligrams if they had renal issues. Again, primary endpoint is stroke and embolism. Again, as you can see here, this was supposed to be a non-inferiority trial. Rivaroxaban incidence of events is less than warfarin. So it is non-inferior and actually better than warfarin. Again, it's the same. Here they have looked into patients who have already been on warfarin or the patients who have never been on warfarin but first time started randomized to either Rivaroxaban and warfarin. In both groups, there is equal benefit. So let's talk about this third drug, Apixaban. Now, this is again a twice daily dosing, 5 milligrams, and if somebody has renal issues, 2.5 milligrams twice daily, as against warfarin. Now, major exclusion criteria, people with mechanical prosthetic valves and also renal insufficiency. Now, what we got to remember with all these drugs is that people who have got valvular disease, prosthetic valves, they still have to be on warfarin. There is no alternative drug yet. So, again, with Apixaban, it's the same. This is actually superior to warfarin. There is 21% relative risk reduction. And again, the major bleeding events are much less with Apixaban compared to warfarin. So now let's concentrate on this. Now, dabigatran has been approved, both 110 milligram twice daily and 150 milligram twice daily. Rivaroxaban is not yet used for atrial fibrillation, stroke prevention in atrial fibrillation. It is used for venous thromboembolism prevention. And same with Apixaban. But these two are going to sort of appear in market pretty soon for stroke prevention in atrial fibrillation. And Rivaroxaban, the trial is almost, the trial is completed, the follow-up period is completed 2 years. We are just awaiting publication of this trial. So now, just to compare, let us concentrate on the bioavailability of these drugs. Dabigatran is about 6% compared to Rivaroxaban, which is 80%, and Apixaban, which is 50%. Now, time to peak is 2 hours, 3 to 6 hours, 3 hours, and 2 hours. Half-life is 12 to 17 hours, 9 to 13, 9 to 14, 8 to 10. These are all comparable, so pretty much in the same range. And what you got to note is dabigatran 80% is by renal excretion. So we got to keep in mind what their renal function is and sort of monitor renal function from time to time. Okay? And also what is interesting, there is no antidote for these drugs. But what is interesting, with 18,000 patients on RELY study, the incidence of major bleeding and fatality secondary to bleeding was less than warfarin. So that we have to remember. So again, I had this trial, this slide, just to show the comparison of the risk factors. So in sort of RELY trial, there was one risk factor, and the trial with Rivaroxaban more than 2, and the trial with Apixaban is more than 1. Again, there is difference in character of the patients that were enrolled. So CHAT score, if you take, the scores are 2.1, 2.2 and 3.5. So slight difference. So you can't directly compare these drugs against each other, because the patients that were enrolled in each of these trials were of different risk sort of factors. Now, just to compare these drugs in terms of ischemic stroke, dabigatran 150 milligrams twice daily pretty much tops the list. But although dabigatran 110 is non-inferior to warfarin, and these two drugs are slightly better than warfarin. In terms of major bleeding, Apixaban is the best, although all these again are very similar and slightly better than warfarin. And same with the stroke, all the 4 drugs are better than warfarin in terms of hemorrhagic stroke. And also mortality rates, although not statistically significant, all the 4 drugs are better than warfarin. So we have discussed these differences, and again, what we find is that dabigatran 150 milligrams twice daily, although the incidence of ischemic stroke is less than warfarin, there is more extracranial bleeding, but this is not statistically significant. And in terms of Apixaban, it actually reduced the major bleeding, but it is, all-cause mortality, there is not statistical difference between warfarin. So summary substance of this is that these drugs are non-inferior to warfarin. If not better, they are non-inferior, but dabigatran 150 twice a day is definitely better than warfarin, statistically significant in terms of reducing ischemic strokes. So, I'm sorry, this is a busy slide. All that I want you to concentrate is about the drug interactions here. We know that warfarin has got multiple drug interactions. What you have to remember with dabigatran is the common drugs that we use. One is the calcium channel blockers, verapamil. When they are used concomitantly to dabigatran, it increases the levels of dabigatran. And if you are going to use ketoconazole, dabigatran is contraindicated. So these are the 2 important interactions that you got to remember. Now, let us specifically talk about dabigatran, because this is widely used in India. Already a lot of patients with atrial fibrillation are on dabigatran. So, what are the factors that you need to take into consideration when you're starting somebody on dabigatran or changing somebody from warfarin to dabigatran? One is the patient age. If the patient is aged more than 75, you would want to use a lower dose of dabigatran, 110 milligrams twice daily, as against 150 milligrams. Again, concomitant medications I have actually just mentioned. And also renal function, you will need to look at their creatinine clearance. If it is less than 50, you don't want to use 150 milligrams twice daily. You want to use a lower dose of dabigatran. Now, bleeding risk, it's the same as with warfarin. The patients who are at very high risk of bleeding, you don't want to start this drug, but there is a score called as Hasbled score. So each of these factors get a score of 1. If they have got a score of 3 or more, then you would want to go for a lower dose of dabigatran, which is 110 milligrams twice daily rather than higher dose. So in this slide, I've just highlighted what I had just mentioned. So the drugs that you got to remember are verapamil, amiodarone, and quinidine. So I'll just sum this up in just next 1 minute. So if you are going to swap somebody who's on warfarin to dabigatran, what you want to do is to allow their INR to fall below 2 and start dabigatran. Okay. And if somebody is on subcut heparin, you will need to start dabigatran 2 hours before their next dose. And if somebody is on intravenous heparin, you can pretty much stop it and start dabigatran. Okay, there is no blood test to check the efficacy of dabigatran, but still if you want to check something, you can check APTT, which is a trough level, just at the time of the dosing of the next dose of dabigatran. If it is more than 80 seconds, then you know that patient is at higher risk of bleeding. Okay. So again, I will pretty much skip these slides. These are slides I have just made to show how to stop dabigatran before minor surgeries and major surgeries. So again, patients who are undergoing PCI and who are on dabigatran, if you are going to have a bare metal stent or a drug-eluting stent and you want to use aspirin plus clopidogrel, the option would be to use lower dose of dabigatran. So that is the common sense. And let's skip this slide as well. And okay, let me just show one last slide. If you are going to switch the patients from vitamin K, so if you are going to switch the patients from dabigatran to vitamin K, so you will need to look at their renal function. So based on the creatinine clearance, when do you start the vitamin K? Because vitamin K doesn't act immediately just like dabigatran or other newer anticoagulants. So you have to plan in advance. You will have to start vitamin K before you stop dabigatran. So that is the only thing you got to keep in mind. So I will sum this up by saying that there are a lot of newer anticoagulants, as I mentioned. One should not hesitate to change from warfarin to dabigatran or the other drugs. At this moment, cost is a factor. Dabigatran costs about 140 rupees a day. Warfarin is pretty much peanuts. So if somebody can pay that amount of money, then they can slip the sort of blood tests, regular blood tests and all that. So, but one should not hesitate to actually prescribe these drugs. I'm quite happy to take any questions if there are.
When we start warfarin, for the first time, we start heparin also to address certain problems. Is it needed?
Dabigatran appears in blood pretty much 1 hour after the dosing. So you don't need...
Haze in the fibrillation?
No, it doesn't. No, they can't be used. Interactions. Not known. So recommendation is not to use in pregnancy and lactation.
Dr. Nagaraj, we have seen that earlier what we are using VKA as the standard drugs and now newer generations which is independent of that. Now, you already mentioned that in an emergency you can monitor APTT and that can give you an idea if the patient is bleeding. So does it mean that if the patients on these newer drugs, or say for example on dabigatran has a bleeding, will the therapy like giving a fresh frozen plasma to counteract effect will be beneficial?
Yeah, dabigatran has a half-life of 19 hours. So if somebody is actively bleeding, it's pretty much supportive therapy and it's got no antidote as such. So giving fresh frozen plasma, blood transfusion, trying to treat the underlying problem. So these are the supportive measures. But as such, there is not a single drug. They are trying to develop one. I believe they are pretty close in sort of developing and bringing out an antidote for dabigatran. But as of today, there is no specific recommendation. It's just supportive therapy.
So at point of time, it may act as a double-edged weapon in that.
Yes, but what is interesting is that the studies with 18,000 patients and patients who were on dabigatran, and then when it was compared with warfarin, the sort of fatality secondary to major bleeding was more with warfarin than with dabigatran. But one thing that I would stress again is that it should not be used in valvular heart disease. There is a study called Realign study where they tried to use dabigatran in prosthetic valves, and it was all nasty results as compared to warfarin. Much more strokes, much more bleeding, much more mortality. So a big no for anybody with valvular heart disease.
So this is at present your recommendation or the standard recommendation only for a non-valvular atrial fibrillation?
Yes.
And just for the benefit of PG students, what about in case of a DVT or a pulmonary embolism on a subsequent oral therapy?
As of now, it is not indicated, but it is indicated for prevention. Post-surgery, we are using Rivaroxaban, Apixaban. Dabigatran is also getting the license. But as of now, it is not the first-line treatment when somebody has already had a PE or DVT. Warfarin still pretty much is. No. It's not an increased risk. There were increased numbers which were not statistically significant. So there was a questions raised by FDA, but then again, as of now, we think it's just a chance that there were slightly higher numbers in this group.
In those groups, we can use a thrombolytic agent as safer agent, or if there is any increased risk of bleeding in those patients.
Dabigatran, when somebody is on dabigatran, it's not a good idea to use thrombolytic agents. No, you should take them for PCI. Yeah.
Sir, actually the oral Rivaroxaban, which is also uploaded for the PTDs and DVT treatment.
Yes, prevention, yes.
For treatment purpose also, they are saying we can use in the mind.
I am not sure. Maybe. It's mainly for prevention, as far as I know.